And it's not just what she did for European and World Rhinology, but what I want to say now is that she has written actually the part on these autoimmune disorders in the nose in the last EPOS 2020 document. Please.
Thank you very much, Liv, and thank you to those of you who have an enthusiasm for this area of our specialty, because it's a really important one, and as you've heard, one that sometimes we don't appreciate. I'm also delighted to be in Thessaloniki, a city that I love, and I'm very relieved for Yanis that everything is going well, so thank goodness. I was asked by the organisers to talk about the role of sinonasal surgery in the diagnosis and management of vasculitis diseases. And I thought, well, that's an interesting topic because it could be a very short lecture. I was interested that our last speaker, Professor Dimitriopoulos, his enthusiasm for surgery was quite marked. But as I'll show you, the evidence is very patchy, and I think we have to be very selective with the cases. Now, you've seen this classification several times now. I don't intend going through it, but I've put in red the three sort of main conditions that we might consider under this topic. And perhaps the first aspect is making the diagnosis. How can surgery help us to make the diagnosis? Well, you've heard all this already. GPA, as was in 2010, originally described by Wegener in 1936. It went through a small transition of being called a C anchor positive disease in the early 2000s, but then it was realized that some of the patients with GPA actually had a positive P anchor, so it became GPA. And characterized, as we've seen, by quite characteristic appearances, but unfortunately not pathognomonic changes on the histology. It's very difficult to actually get a handle on how common these diseases are. We see estimates of perhaps 25 to 30 people per million from Europe and the United States. But it isn't actually certain how frequent these cases are, and the reason for that is this way in which the vasculitic diseases present. We've heard that there are classical generalized forms of vasculitis, which was how it was described back in the 1930s, where the patient may have many systems involved. But we also recognize, particularly in ENT, that there are limited and localized forms of the disease. And I'd be interested to know in our discussion with the last speaker whether he thinks that all patients with localized disease, given enough time, would go on to have systemic disease. Certainly, I've had many patients with limited disease, particularly GPA, where I followed them up for quite a long time, and the decision as to whether to start a systemic medication can be quite a difficult one if all they have is symptoms in the nose, throat, or ear. It's a very broad disease in terms of age and distribution by sex. The majority of cases that we see are Caucasian in origin. But we are, as ENT surgeons, at the sort of front line of vasculitis because any organ can be affected, but it often starts in the upper respiratory tract, in fact, in about 2/3 of the cases. On a positive note, if you present with ENT involvement, then you do have a better outcome and a higher survival than those who present with more aggressive systemic disease. Now, I've been very fortunate over my career to look after a lot of patients with vasculitis, both independently and in recent years in collaboration with my physician colleagues. And we have quite a large cohort of whom we did a number of studies on. And this is a group of just under 200 patients where we actually asked them about their symptoms and the speed with which they were diagnosed. And you can see here, if we break down the symptoms by system, that the nose and sinuses actually constitute just over 40% at the time of their presentation. And at the time of the questionnaire, when they had already been diagnosed, 64% of these patients still had active involvement of the sinonasal tract. Now, as you've heard from both the other speakers, we all know these patients present with some nasal blockage, sometimes some facial pain, quite often some loss of smell. And those are very common symptoms that we all see every day in the clinic. But it's really the crusting and the bleeding that really signals that alarm bell. And the facial pain is an interesting symptom because it may actually relate to involvement of the underlying bone and be part of an osteitis, as I'll show you. We always think of patients having a collapsed nose, and that certainly can occur in GPA, but it's not in the majority of the cases that I've seen. Certainly about a quarter of the patients get this collapse. But what is noteworthy is that in GPA, the collapse of the nose is really quite characteristic. You can get something very similar in relapsing polychondritis, but it's quite different from the collapse that you see after an over-enthusiastic septal resection, for example. And you can see here in this lady, you almost feel as though you could pull the nose out. Now that can occur even if the patient does not have a septal perforation. But of course, when you look in the nose, it may often give the game away. It can look just like rhinosinusitis, but it can often show this very granular, friable appearance with adherent crust, with old blood, etc. And that, again, is the big alarm bell ringer. I'd also draw your attention to the adhesions. If you've done a procedure, or even if you've done no procedure, and the patient comes with a lot of adhesions, think, could this be GPA? It's quite a common presentation. And then when it comes to imaging, of course, we frequently see mucosal thickening. We often see bone destruction, which can be quite dramatic on the skull base. And we can see bone thickening, a sort of evidence of this osteitis that I mentioned, together with the septal perforation. And the reason I mention the osteitis is that many years ago, we described a sign on the back wall of the maxillary sinus where you see these two lines of the bone, a so-called tram line, which is particularly obvious on the CT, but can be seen on the MRI, and is absolutely specific to GPA. So if you ever see that in a patient with chronic rhinosinusitis, think, could the patient have GPA? Now, what about the surgery? That's what I'm supposed to be talking about, the diagnosis. Well, here we are, the histopathology, as we've said. 3 criteria: necrosis, granulomatous inflammation, and vasculitis affecting the small to medium-sized vessels. And of course, if you look for them, you can find in the granulomas a variety of cells, specific T cells, histiocytes, lymphocytes, neutrophil, granulocytes, macrophages, etc., and central necrosis. But the problem is that if you look in the literature and from personal experience, it's actually quite difficult to get a classical report from your histopathologist, even if they're really expert head and neck pathologists. Because one of the problems is that the tissue you get may not show these characteristics. And that's particularly true if you start biopsying around septal perforations. And I think the mantra has to be that if it looks normal, then it probably is normal. And so it's got to be abnormal tissue that you biopsy. And what I used to get from my pathologist, who would be a very senior head and neck pathologist, they would report it as consistent with. It's quite difficult to get them to commit that it was definitely a case of GPA. And in fact, interestingly, in the literature, it seems that biopsying the sinus mucosa may actually be more useful, and that's certainly true in both GPA and sarcoid. The one situation where it is quite useful is if the patient is already had an anchor test, and if it has been shown to be negative, but you can get some tissue that looks very abnormal. And if anything, I would say that the use of surgery for diagnosis in GPA is actually most useful for differential diagnosis. Because if you have a patient with a scan like this, who's obviously missing a very significant part of the mid portion of their face, then you have to consider not just GPA, but also cocaine abuse, as you heard from Professor Trimarchi, and in addition, things like invasive fungal rhinosinusitis and a NK T-cell lymphoma. So those are two things in red which you need to diagnose, and you need to diagnose pretty quickly as well. So if the tissue is abnormal, then a biopsy is certainly worth doing, if only to exclude those conditions. Now, because of this issue about limited or localized disease, and the fact that patients may come with just nasal obstruction and a bit of discharge and some spotting of blood perhaps, it's very common for patients to wait quite a long time before they're diagnosed. This is our study, which showed, as you can see, rather disappointingly, 43% of patients overall had waited within 6 to 12 months for their diagnosis from the presentation of their disease. And during that time, these patients had been to see ENT surgeons who had not realized what was going on. And it was only when the patients became systemically unwell and ended up in intensive care and a clever physician said, oh, this could be vasculitis, that the diagnosis was made. And then this was in the UK. I have to say there have been studies from the United States and other countries showing exactly the same. So we really have to be very suspicious. We have to have a very low threshold of suspicion for vasculitis if we're going to diagnose them. Now, of course, we can say, okay, we've got this wonderful test now, we can do an anchor test, we'll know straight away. And that's certainly true if the patient has classic systemic disease. And we can confirm that positive anchor with a proteinase 3 study, and that is a really strong test for diagnosis. But in localized GPA, and Dr. Dimitriopoulos showed that as well, that it becomes much less of a help, and the sensitivity drops quite a lot. And as I also mentioned, it's possible to have a P-anchored test that is positive in GPA rather than a C-anchored test. I won't say much about this. Matteo gave a very lovely lecture just at the beginning about all the work they've done on cocaine abuse and how this can very closely mimic GPA. But again, you really need to have it at the back of your minds. It can be quite difficult sometimes to ask patients, are you using something in the nose? And they say, what did you have in mind? And you have to sometimes spell out the fact that you think they could be using cocaine. So, you've used your surgical technique to take a biopsy. Are you going to use it to treat the patients? Well, I think it's quite a difficult discussion. I mean, clearly, we're going to use topical things in the nose. We've heard the very excellent lecture about all the drugs now that can transform the patients. And cleaning the nose out can be a very helpful thing for many patients. Regular debridement, if the patient asks us to do it. Should we be operating to actually rectify some of the damage that the disease has done? Well, my sort of golden rule, and it's based on bad experiences of being more enthusiastic when I was younger to do things to rectify the situation, is that you should wait until you feel reasonably confident that the disease is burnt out. What do I mean by burnt out? I mean that the patient has not had any major relapses during the last year and is at least stable on a relatively low dose of medication. Otherwise, your efforts will be wasted, and you may actually blow the opportunity of getting a good result in the long term. Now, there are reports in the literature for doing any and all of these operations, though, of course, no randomized controlled trials, and very small numbers. We're talking usually a handful of cases. Endoscopic sinus surgery has been used to treat facial pain. Well, I showed you that the facial pain is likely to be due to osteitis, so it's little surprise that the outcomes for this have been rather poor. And of course, if you start operating in the nose with its active disease, you will get scarring and adhesions. Many of the patients have lacrimal involvement, and again, the same problem applies. It's often difficult to get good results because of the adhesions. If you have a lot of skull base loss, as I showed you, and we've certainly had patients with CSF leaks, then it's worth doing an endoscopic repair. There are very few papers in the literature, but it does work in these selected cases. What about repairing the septal perforation? Well, unfortunately, however good you are at repairing septal perforations, the long-term results of this are not great in GPA, and you might consider a septal button or nothing. I have stopped ever offering surgery for the septal perforation in these patients quite a long time ago. And the loss of the external bridge of the nose, augmentation rhinoplasty, there are reports in the literature. The results are good if the disease is quiescent. Must never use artificial materials because it will extrude, but pinna cartilage can be of benefit. But if you put it in too early, it will simply resorb and you will lose that opportunity to construct in the future. Few words on EGPA. We've heard about it from the last speaker. It is well defined as a disease. It's pretty rare, we think, 6 per million per year in the UK, and I know that I have 48 patients, but I might have had quite a lot more patients than that, because if you look at the symptom set, nasal polyps, allergic rhinitis, asthma, eosinophilia, how many patients does that describe in your clinics? Quite a lot, and some of them may have had EGPA. So again, I think we have to have a low threshold of suspicion and look actively for more systemic manifestations, which might involve the nerves, it might involve the heart or the lungs. P anchors may be helpful, but only in about 50% of the cases. And we might see these patients in that prodromal phase before they go on to the more serious problems, particularly the vasculitic phase, which can be associated with fatality if it isn't picked up in time with all of these other conditions. So I think that we have to again accept that there is a mean delay in diagnosing these patients. If they just have CRS at the outset, then again an 18.5 month delay is reported, and you can understand why that might be. If the patient also has asthma, that delay is reduced to 11.8 years. So if you are seeing patients who have difficult to treat type 2 dominant disease, which is of course often patients with polyps, but can be a patient without polyps, please think about EGPA. The topical treatments, it's the same usual suspects: steroids, irrigation, lubricants, perhaps less so in this case. Surgery, actually, this is where it can really be of use. It's like treating any other severe nasal polyp patient. You can undertake your endoscopic surgery for their polyps. Some of them have associated mucoceles. These are conditions which we are eminently able to treat endoscopically. Obviously, the systemic medications which you've heard about will help reduce the symptoms and control them, but the patients may often be left with residual disease in the nose, and you can address that endoscopically. I looked at 25 of my EGPA patients, and you can see that just under half of them had already undergone endoscopic surgery, often multiple times prior to their diagnosis. So I'm not saying you can cure anybody with surgery, but you can certainly control or help to control their symptoms. And then finally, just a few words about nasal sarcoid. Here we've got a non-necrotizing granuloma characterized by these cells, as you see here on the histology slide. This is predominantly a lower respiratory tract disease, but it can affect any system of the body. It's estimated that about only 4% actually get problems in the nose. I worked at the Brompton Hospital in London for some years in the past, and there were dedicated clinics for sarcoid patients. So there you thought it was quite a common disease. So when I went back to my rhinology clinic, I looked at over 5,000 patients to see how many of them I'd actually diagnosed with sarcoid de novo, and there were only 23. So even in a tertiary rhinology clinic, it's not a common disease, but again, you have to keep an open mind. Similar symptoms: nasal stuffiness and obstruction, the classical crusting, and a blood-stained discharge, as well as some of the other commoner symptoms characteristic of a chronic rhinosinusitis. Externally, you may see a red nose, lupus pernio, on the tip of the nose, as well as elsewhere in the body. And when you look in the nose, it can look sort of dreadful, friable, granular. But classically, you sometimes see this appearance where there are little white granulomas dotted over the surface, and behind it a background of quite inflamed mucosa. And it looks just like a strawberry skin. From a point of view of imaging, it may just look like chronic rhinosinusitis again, but they do have one characteristic feature. If you look at the hands of patients with sarcoid, they sometimes show classical lesions in the metacarpals. But if you look at the CT scan, or indeed a plain X-ray, very rarely done these days, but of the nasal bones, you will often see these punched out lytic lesions, which are quite characteristic of sarcoid. You may also see a sort of nodularity on the mucosa on the CT scan, and evidence of both bone erosion and new bone formation. So these are not absolutely pathognomonic, but the lytic lesions, if you see them, are very, very suggestive. Now, unlike GPA and EGPA, there's not any single blood test that gives us the answer as to whether or not the patient has nasal sarcoid. And ultimately, patients often do undergo a biopsy, particularly by our physician colleagues, of the bronchi or lymph nodes. So what about biopsying the nose? Again, we are often asked to biopsy the nose to see if there is sarcoid there. Well, this is a very old study that I did when I was much younger at the Brompton Hospital. And we looked at a group, quite a large group of patients with sarcoid, and we looked and took biopsies, whether or not the nose looked abnormal inside. And what it showed us was, again, if it looked abnormal, then it probably was abnormal and gave us the diagnosis. But if the mucosa looked normal, the edge of a perforation or the lining looked completely normal, then in most of the cases, 92%, it was negative. So the message is, if it looks bad, go for it, and if it doesn't, there's no point. Again, the patient may benefit from some regular debridement in terms of their surgical management, but I have to say that for the long-term management of nasal sarcoid, surgery, in my view, is rarely indicated. You might be persuaded to debulk the inferior turbinates or any sort of polypoid tissue. You might be persuaded to do endoscopic sinus surgery if the sinuses are opacified on a CT scan and the patient has a lot of symptoms. Does it help you? Well, it can sometimes confirm the diagnosis because you get tissue from the sinus which confirms sarcoid. It may debulk the tissue, and in one paper was suggested that it would reduce the needs for systemic steroids. It was not a randomized controlled trial, I have to emphasize. I would be very hesitant to operate on the septum in a patient with sarcoid because you stand a very high chance of creating a perforation. And what about reconstruction of the nose? Well, people have published papers on doing flaps, forehead flaps, for example, for lupus pernio. But again, in my experience, the lupus pernio fluctuates with the severity of the disease, and it will also respond quite well to the systemic treatments that the patients are now given. So here's a lady who came to me requesting a rhinoplasty, and you can see the result. One of my best rhinoplasty results, because it was with oral steroids. She had sarcoid. The giveaway, of course, is the lupus pernio on the cheek, and a course of oral steroids in those days. She'd probably be given something else these days, but in those days, and her hump on the nose went and disappeared completely. So the message really is surgery has a place, but it's very, very limited in the vasculitic conditions. The thing that's most important is the diagnosis, to actually suspect that it can be there, and that's why it's included in the purple box for EPOS, for the management scheme in diffuse CRS. Bleeding, crusting, cocosmia, these sort of symptoms should really ring alarm bells. You do need specialist pathologists and representative tissue to deal with this, and even then it can be difficult to make the diagnosis. But perhaps the most important thing is the differential that you're trying to exclude other more serious conditions, and if you want to operate, wait really until things have settled down. I think EGPA is likely underdiagnosed, and if you have patients with difficult to treat CRS with nasal polyps, have a think about whether this could be there, because if you don't think about it, you won't diagnose it. And I echo finally the message from the last speaker: share the pain, manage these patients collaboratively with the physicians. I've been lucky enough to run joint clinics with these physicians over the years, and it makes your life and the patient's life that much better. Thank you very much.
Very much. I would suggest that you come here, and Dr. Dimitrioulas also, and I will go there because I was sitting all the time, and we will accept questions, and you can also discuss, as Dr.